Good afternoon, everyone. Today, we are going to talk about the physiology of the thyroid gland. So, I'm Dr. Ana Angelica Macalalad Josue, and I'm an internist and an endocrinologist. So, for today's lecture, this will be our outline. So, first, we're going to talk about the synthesis and secretion of thyroid hormones. Next, we're going to talk about the physiological functions of the thyroid hormones. And then we're also going to talk about how thyroid hormone secretion is regulated. And then lastly, we'll just talk briefly, very briefly about some of the diseases of the thyroid to help you understand, um, or remember the functions of the thyroid hormone, because usually when in the disease states, they are exaggerated. So the thyroid gland is responsible for producing three major hormones, or actually just two major hormones. Calcitonin is just a minor hormone from the thyroid gland, but the majority of the thyroid hormones that come from the thyroid gland is your thyroxine, or your T4, and your triiodothyronine, which is your T3. Majority of the thyroid hormones that come from the thyroid gland is your T4, which is about 93% of the hormones that is produced by the thyroid. So they both profoundly increase the basal metabolic rate, and the major regulator is your thyroid stimulating hormone from the pituitary gland, which is your master gland. So your thyroid gland weighs approximately 10 to 15 grams. For normal thyroid gland, it can, in disease states, it can grow as big as 100 grams. No? So it depends on the etiology. And it's mostly composed of thyroglobulin, and the thyroglobulin is this one inside, contains the thyroid hormones. It's the storage form of the thyroid hormones. It's a large glycoprotein that is the major constituent of the colloid of the goiter. So this is the colloid, and this is your cuboidal epithelial cells. So in disease states, your cuboidal epithelial cells will become, will look more like stratified epithelial cells because of the increased activity. So your thyroid gland comes from the endoderm of the floor of the primitive oral cavity in the region of the future foramen cecum in your ultimobranchial body. So the thyroglossal duct, if it persists, is actually a remnant of this migration from the floor of the oral cavity to its location in the anterior neck. So some patients, if there is a failure of migration, some patients will have a lingual thyroid. So your thyroid gland will be located at the base of your tongue. So those are usually patients that present with congenital hypothyroidism, when there's failure of the thyroid gland to migrate from its origin in the oral cavity to the anterior neck. So that's how I try to remember the embryology of the thyroid gland. So the blood supply of your thyroid gland comes from the superior inferior thyroid artery. So this is it. Okay, the superior and the inferior thyroid artery, as well as superior, middle, and inferior thyroid veins that drains the thyroid gland. And these are the lymphatic drainage and the nerve supply. So the nerve supply comes from the middle cervical ganglia. So if you look closely at the thyroid gland under the microscope, if you recall from your histology, they would look like this. No? So the cuboidal cells would look very nice here. surrounding your colloid. The whole thing is your thyroid follicle. The thyroid follicle is composed of the cuboidal epithelium and the colloid is the one that contains your thyroglobulin, where your thyroid hormones are stored. And in between will be your parafollicular cells, the cells responsible for secreting your calcitonin. So the first step in thyroid hormone synthesis is first your iodine from your diet. When you eat a regular iodine diet, it will be absorbed in the body and it will be trapped in your thyroid gland. So majority, if not almost all of the iodine that you ingest goes to your thyroid gland. It's concentrated there. There are some other tissues in the body like your salivary gland, your bladder can have some small iodine uptake, but majority will be to the thyroid gland. So your thyroid gland is very efficient in trapping iodine, and it does that by the sodium iodide symporter, or your NIS. And the sodium iodide symporter co-transports one iodide ion along with two sodium ions. So it's a co-transport or a symporter. So it's the same way going inside. No? And in this one, this symporter is powered by your sodium potassium ATPase pump. So your sodium potassium ATPase pumps out the sodium, and the gradient now will the gradient of the sodium will drive the symporter to for the sodium to go inside, and with it, it will bring your iodide ion. So the sodium iodide symporter is able to concentrate the iodide to about 30 times its plasma concentration. And the rate of the trapping of the iodine is influenced mostly by your TSH. So if you have hyperthyroidism, so if you have central hyperthyroidism, meaning you have excess TSH coming from your pituitary, there will be an increased activity also of your sodium iodide symporter. Okay, so because TSH affects almost all the steps of thyroid hormone synthesis. We also have another transporter on the colloid side, no? On the colloid side, or the apical membrane side, no? Into the follicle, called the pendrin. So your pendrin, on the other hand, transport your iodide to your colloid through a chloride iodide counter transport system. So next, once your iodide enters the cell, so at the same time, no, there's also formation and secretion of your thyroglobulin. So your thyroglobulin is a large glycoprotein molecule. So it's a protein with glucose residues. No? And it's synthesized from 70 tyrosine amino acid, because tyrosine is one of the amino acid precursors of your thyroid hormones. And your thyroid hormones form within the thyroglobulin, because that's where your tyrosine amino acid precursors are located, no? Okay. So these two can occur at the same time. So once your iodide is trapped inside the thyroid follicular cells, it enters your colloid, and this is where it is oxidized. Your iodide is oxidized into iodine. No? And this is promoted by your thyroid peroxidase hormone, or your TPO. So your thyroid peroxidase hormone is one of the thyroid peroxidase enzyme is one of the more important enzymes that you need to remember in thyroid hormone physiology. So the oxidation of your iodide ion is facilitated by your thyroid peroxidase enzyme. Okay, and after your iodide ion is oxidized, it is now organified. So when we say organified, the iodine is bound to tyrosine residues that comes from your thyroglobulin to form your MIT there and your monoiodotyrosine and your diiodotyrosine. And this is also hastened by your thyroid peroxidase enzyme. So again, your organification is the binding of your tyrosine residues to your iodine to form your MIT and your DIT. We now I'd like to introduce to you the Wolff-Chaikoff effect. So the Wolff-Chaikoff effect is something that happens it's a phenomenon that happens when you have very, very high levels of iodine. Normally, you would think that if you would give lots of iodine, lots of ingredients for thyroid hormone synthesis, that it will actually increase thyroid hormone production. But in fact, in the Wolff-Chaikoff effect, if you give a patient high levels of iodine, it will actually inhibit organification and therefore inhibit thyroid hormone synthesis. That's why in patients with thyroid storm is like a very exaggerated state of thyrotoxicosis or very excessive thyroid hormones. We give high doses of iodine in order to block the synthesis of thyroid hormones through the Wolff-Chaikoff effect. Okay, so very high levels of iodine can blocks organification, therefore preventing thyroid hormone synthesis or limiting thyroid hormone synthesis. So next, we have your coupling reaction. The coupling reaction is when the combination of the organified iodine, your MIT plus DIT, will combine to form T3 or RT3, and two DIT residues will form T4. So 1 plus 2 equals 3, 2 plus 2 equals 4. So as simple as that. And then so that's the coupling, that's your step 5. And your iodinated thyroglobulin is stored in the follicular lumen until the gland is stimulated to secrete thyroid hormones. No? So your T4 is more active than, your thyroid gland produces more T4 than T3, but T3 is more metabolically potent and more metabolically active. So the MIT, DIT within your thyroglobulin also will form your T3 or T3, T4, which is also stored within the thyroglobulin. So, and then lastly, the release of thyroid hormone. So the iodinated thyroglobulin is taken back into the follicular cells through pinocytosis. No, the follicular cells the apical membrane will form pseudopods in order to engulf some of the thyroid glands, thyroglobulin to enter the thyroid hormone cells, and then here inside the thyroid hormone cell, thyroid follicular cells, the lysosomes digest the thyroglobulin molecules from from the T3 and T4 from the thyroglobulin in order to release the T3 and T4. Where T3 and T4 will now diffuse into your plasma. There's another alternative way of aside from pinocytosis, your thyroglobulin can also bind to megalin and be endocytosed into the cell as an alternative form of entry of your thyroglobulin into your thyroid follicular hormone. So again, your thyroglobulin re-enters your thyroid hormone, your proteases cleave the thyroglobulin and release the T3 and T4 into the plasma. Okay. So if you look at the biochemical structure of the thyroid hormone production, so the amino acid precursor will be tyrosine, and it will be iodinated to form monoiodotyrosine. If another iodine is added, it becomes diiodotyrosine. So if you combine MIT plus DIT, you have T3. If you combine, and then if it's or RT3, or if it is DIT plus DIT, it becomes T4. So that's the location of your iodine in your iodinated tyrosines. Now, the deiodinase enzyme, another important enzyme that you need to remember in thyroid hormone physiology, is the one that cleaves iodine from them for recycling within the gland for additional thyroid hormones. Let's say you don't need too much T3, you just need T4, then your the iodinase enzyme can get iodine from your T3 as well. So your thyroid gland is unusual in its ability to store large amounts of hormones. Unlike the other glands in the body, like pituitary or your ovaries or your testes, no, they don't really store large. Even your adrenals, they don't really store large amounts of hormones. But thyroid um can store large amounts of hormones. So even if you are iodine deficient, you're unable to synthesize new thyroid hormones for 2 to 3 months, the thyroid gland can still be able to supply your body with normal thyroid hormones. Or sometimes in pathophysiologic states like the Hashimoto's thyroiditis, where your thyroid gland is destroyed, you don't become hypothyroid right away because you still have some preformed hormones that are stored in your thyroid gland, and it will take some time for it to be depleted. So how does your T4 and T3 reach your peripheral tissues? So most of the T3 and T4 is bound to your plasma protein called the thyroxine binding globule, and to a lesser extent also your prealbumin and albumin. So the level of total T4 and total T3 can be affected by factors that affect the levels of thyroxine binding globulin in the body. So for example, if you have hepatic failure, remember that your liver is the organ that synthesizes plasma protein. And since PBG is a plasma protein, in patients with hepatic failure, you will have low levels of thyroxine binding globulin. And in total, there will be lower total thyroid hormone levels. But the levels of free hormone, free T3 and free T4 will still be normal. Likewise, in pregnancy, you will have increased thyroxine binding globulin level, and there will be a corresponding increase in total T4 and T3. But again, the levels of free T4 and free T3 will remain unaffected. So in both states, you will be still clinically euthyroid. But when you do thyroid function testing, it will affect it. So that's why in most instances, we request for free T3 and free T4 instead of the total T3 and T4 because it's less affected by these factors. So we rarely request total T3 and T4 anymore in the clinics. Okay? And thyroxine and triiodotyrine are released slowly to the tissue cells from the thyroxine binding globulin. So now we compare what's the difference between T3 and T4. Why do we have to have two kinds of thyroid hormone? So in terms of production rate, majority of the thyroid hormone that is produced by the thyroid gland is your T4. No? And your T4, diba, I told you earlier, 93% of the thyroid hormone that is produced by the thyroid gland is T4. And then it goes into the peripheral tissue where it becomes, it is converted to T3, which I will discuss in the next couple of slides. But in terms of metabolic potency, it is T3 that is more metabolically potent, and it is also the one that it's used in the peripheral tissue. In terms of serum concentration, you will have more total and free T4 simply because the thyroid gland produces more T4. But the fraction of total hormone in free form will be more of T3. Why? Because it needs to be free in order to be metabolically active. No? If it's bound to your TBG, it cannot act on the peripheral tissue. That's why more T3 is in the free form in order because it should be the one that is because it's the one that's more metabolically active, and it's also the one that is utilized by the peripheral tissues more than T4. The distribution volume, the T3 is more distributed in the body simply because in the peripheral tissues your T4 is converted into T3. And then in terms of half-life, your T4 has a longer half-life because more of it is bound to your thyroxine binding globulin, making it less susceptible to metabolism. Okay, and the half-life of T3 is just less than 24 hours. And lastly, your affinity to plasma protein. So your T4 has a higher affinity to your plasma protein, and your T3 will have a lower affinity. Why? Because it needs to readily diffuse into the tissues. Because again, it's the one that is needed by the peripheral tissues more than your T4. Okay? So I've been talking to you about the peripheral conversion of T4 to T3 in the target tissue. So more than 90% of the thyroid hormone molecules that bind with receptors is T3. No? So that's why in the peripheral tissues, let's say in your skin or in your heart or in your GI tract, you will have receptors for T3. No? So when your T4 reaches your peripheral tissues, it needs to be converted first to T3 through your deiodinase 1 enzyme in order for T3 to be attached to the receptors in the peripheral tissues. And this will result in biological activity. Sometimes your T4 will be acted upon by your deiodinase enzyme 3 or your T3, and this deactivates or inactivates your T4 to your reverse T3, no? Which does not have any significant biologic activity. Your T3 can also be deactivated by your D3 to inactive T4. So your D3 is the enzyme responsible for metabolizing your T4 and your T3 in the peripheral tissue. And your PTU, it's a drug used for hyperthyroid patients. It also blocks the peripheral conversion of your T4 to T3. So I hope that's clear. No? So this is just a snapshot of the entire thyroid hormone synthesis for your review. Okay. So now, next we go to the physiological functions of the thyroid hormones. What does your thyroid hormones do to your body? Okay. So this is what happens when your T4 and your T3 reaches your target cell. So let's say this is the target cell. So your T3 diffuses into your target cell, or if it's your T4, it's converted by your deiodinase enzyme to T3, and it is your T3 that attaches to your thyroid hormone receptor. And remember, your thyroid hormone receptor is located inside the nucleus, no? So remember that the different hormone receptors can either be located in the cell membrane, located in the cytoplasm, or located inside the nucleus itself. So for thyroid hormone, the thyroid hormone receptor is located inside the nucleus. So what happens when your T3 binds to your thyroid hormone receptor? Your thyroid hormone receptor is already attached to your thyroid hormone response element. So your thyroid hormone response element is a segment of the DNA. It's a segment of the DNA. So that when your thyroid hormone receptor is activated, it triggers the gene transcription. No? Once your thyroid hormone attaches to your thyroid hormone receptor. So once the thyroid hormone attaches to the thyroid hormone receptors, the retinoid H receptor is released. In this one kasi, what it does is it inhibits the gene transcription. But this inhibition is released once your thyroid hormone is released into your is attaches to your thyroid hormone receptor. So that in order for gene transcription to proceed. So once gene transcription is allowed to proceed, it will now result in synthesis of new proteins, and the new proteins, usually they're enzymes, they will now be powering all the metabolic effects of your thyroid hormones in the cells, no? Such as growth and CNS development, cardiovascular, and metabolism. So your thyroid hormones increase cellular metabolic activity. So by about, if there is large amounts of hormones that are secreted, it increases basal metabolic rate by about 60 to 100% above normal. And this results in increased rate of utilization of foods for energy. So patients with hyperthyroidism, their appetite is increased. But despite eating a lot, no, they don't gain weight. Sometimes they even lose more weight. And this is because of the increase in metabolism. It also increases mental processes. So that's why patients with hyperthyroidism, they usually have difficulty sleeping at night because it's like their brain is always running and running, and they're usually anxious. Their thoughts are never ending. On the other end, for patients with hypothyroidism, usually they're very lethargic. You ask them in the clinic, how are you, sir? And it will take them a few minutes before they answer because their mental processes are slowed. And this is because of the lack of the thyroid hormones. Your thyroid hormones also increases activities of most of the other endocrine glands. So, and it also increases the number and activity of the mitochondria in order to increase ATP production, and the increase in ATP production is needed in order to power the increase in basal metabolic rate. It also increases active transport of ions through cell membranes through the sodium-potassium ATP, like the sodium-potassium ATP pump. And I think this also contributes to the increase in activities of most other endocrine glands. So your thyroid hormones really affects the whole body. That's why patients with hyper or hypothyroidism will have systemic manifestations. So your thyroid hormone is very crucial on growth and development of the brain, together with your growth hormone and your somatomedins. Your somatomedins are your IGF, no, your insulin-like growth factor, and they both help in bone formation. So in terms of bone formation, your thyroid hormone is responsible for bone maturation and particularly your ossification and fusion of your growth plate. So this is an X-ray of, it looks like an X-ray of an infant, no? But this is actually a 36-year-old female, and look, the bones are not fused together, no? And this is when you do bone aging, this is actually equivalent to a bone of a 3-year-old. And the distal bone will be equivalent to the age of a 1 year and 3-month-old person. No? But this actually, the chronologic age is 36 years old. So if you have thyroid hormone deficiency at birth, no, or during infancy or even childhood, your bone age is less than your chronologic age, meaning your your age is older than your bones. Okay? So you will have epiphyseal dysgenesis there. Your epiphyseal plate has not matured. Okay, there is shortening of the long bones because of the ossification is not does not proceed normally. You will also have a large fontanelle and a wide suture. This is a picture of so that to help you remember, this is a patient of mine. She's a 30-year-old female who presented to us because of menorrhagia, and this is because of the long-standing hypothyroidism. She had an untreated congenital hypothyroidism secondary to thyroid dysgenesis. She only had a small, tiny lingual thyroid, no? And she had stunted growth and mental retardation. So the difference between growth hormone and thyroid hormone affects both brain and growth development, but growth hormone only affects growth. So patients with growth hormone deficiency during infancy or congenitally will have normal brain development, but will be usually will manifest with dwarfism. So that's the difference between thyroid and growth hormone in terms of growth and development. Um, okay. What are the effects of thyroid hormones on specific body functions? So in terms of carbohydrate metabolism, there's rapid glucose uptake by the cells, everything is enhanced, both glycolysis, gluconeogenesis, even glycogenolysis. Some patients will actually manifest with diabetes as well, no? Although this hyperthyroidism is not famous for secondary diabetes, but they can coexist as well. There's also increased absorption from the GI tract, increased insulin secretion, everything is increased. So in terms of fat metabolism, lipids are mobilized rapidly from fat tissue. That's why patients with hyperthyroidism present usually with very, very, very thin bodies, and this results in decrease in fat stores. And because of this, there's also because there's increased lipolysis, there's increased free fatty acid concentration in the plasma and increased rates of fatty acid oxidation. So there's in protein wise, there's increased protein synthesis, both protein synthesis and degradation. But actually it's degradation usually overcomes the rate of protein synthesis, but both are actually increased. But the end result will be muscle wasting as well. So you'll see patients with hyperthyroidism to have, aside from very small, thin fat, no, you will also have thin muscles as well. And the end result will be a decrease in body weight. No? Even they say that I eat a lot, doc, but I keep on losing weight. No? So the overall effect of thyroid hormone is catabolic. So it's the opposite of your insulin. Your insulin is anabolic. So your thyroid hormone aims to break down, no, carbs, fats, and protein. The end result is catabolic. How about effect on plasma and liver fat? So your thyroid hormone decreases concentration of cholesterol, phospholipids, and triglycerides in the plasma. That's why patients with hypothyroidism, no, those who lack thyroid hormones will have markedly elevated cholesterol levels. So if you treat the hypothyroidism, you can normalize the lipid levels even without giving patients anti-cholesterol drugs. And this is because of the effect of your thyroid hormones on your lipids. Your thyroid hormone also increases requirement for vitamins, because remember, your vitamins are needed for enzymes and coenzymes, and your enzymes and coenzymes are in overdrive because of the increase in metabolism. How about in the heart and the lungs? Everything again is powered or increased by your thyroid hormone. So there will be increased blood flow and cardiac output. There can be vasodilation. And the vasodilation really is because in order to disseminate the excess heat production from the increased metabolism. So if you have increased metabolism, heat is produced. So this the patients with hyperthyroidism will have warm skin. They will have warm and moist skin, and this is because of the vasodilation. And the excessive heat is disseminated by increasing blood flow, and this is promoted by vasodilation of your um, skin, in the skin. There's also increased heart rate because of the direct effect on the excitability of the heart. So patients with hyperthyroidism will have palpitations, they will have increased heart rate. Patients with hypothyroidism, on the other hand, especially those with profound hypothyroidism, will have slow heart rate or bradycardia. Heart strength, no? If thyroid hormone production is too excessive, the heart muscle strength is depressed because of excessive protein catabolism. That's why we also have what we call thyrotoxic heart disease, no? And there's also increase in pulse pressure. Remember, your pulse pressure is the difference between your systolic blood pressure and your diastolic blood pressure. And this is because of the vasodilation. There's also an increase in ventilatory rate because you need more oxygen delivered to the tissues to supply, to drive ATP production and the ATP is needed for the increase in basal metabolic rate. In the GI tract, you will have increased appetite and food intake, increased motility. In patients with uncontrolled hyperthyroidism, they can have, actually it's not diarrhea, it's actually hyperdefecation. There's frequent defecation, but the stools are not really loose. No? They just go to the bathroom about 3 to 4 times a day. In patients with profound hypothyroidism, they can have constipation. Sometimes we also have, in severe cases, we have myxedema colon. Myxedema colon is that the colon will just stop moving. And since the colon will stop moving, usually there's fecal stasis, fecal infection, even at worst, no? And sometimes functional colonic obstruction as well, because your colon doesn't like to move at all. How about in the nervous system? In hyperthyroidism, patients will be hyperexcitable, irritable. In patients with hypothyroidism, so patients with hyperthyroid, they will describe their mind is always turned on. Now, even if they want to sleep, they cannot turn it off. In hypothyroidism, it's the opposite. No? They usually have excessive daytime somnolence, slowed speech, poor memory, and decreased mental capacity. But usually it takes a long time for these manifestations to show in patients with hypothyroidism. They have to have very, very, very low thyroid hormone levels to manifest all of this. For the autonomic nervous system, it's the same actions as the sympathetic nervous system because it also upregulates alpha adrenergic receptors in the heart. So that's why we can use beta blockers such as propranolol in order to control the effects of the thyroid hormones on the autonomic nervous system, particularly your sympathetic nervous system. So you can use beta blockers to slow down the heart. With sleep, just like in your CNS, difficult to sleep, hypothyroid extreme somnolence. How about in the muscle? So there is the slight increase in thyroid hormones usually makes the muscles react with vigor. So patients with hyperthyroidism, they would manifest with a fine tremor. So when they sing in the mass, sing during Our Father, or some patients would describe it as pasmado. No? So this is because of the increased reactivity of the neuronal synapses from the excessive thyroid hormone. In hypothyroidism, it's the opposite also. Sometimes if patients come to you with in coma, and you don't know if this patient has a thyroid problem, let's say you're not sure if this is a thyroid storm, you can actually check the reflexes. If the patient has hyperreflexia, that's a sign of thyrotoxicosis. If the patient has hyporeflexia, that's a sign of hypothyroidism. So it slows down your muscle contraction. The thyroid hormone and sexual function in men could be loss of libido or impotence. In women, usually it's very similar in presentation, hyper or hypothyroid. So it also has an effect. And remember your your thyroid hormone, if it's very depressed, no, your T4 and T3 is very low, it will result in elevated TSH. And remember, your TSH also affects not just your FT3 and FT4, but also your prolactin production. Oh no, sorry, TRH. So when you have hypothyroidism, you will have very high TSH, and the very high TSH will also have high TRH. And remember, your TRH, your thyroid releasing hormone, also affects not just TSH but also prolactin. So some patients with hypothyroidism can also have hyperprolactinemia. So how is thyroid hormone secretion regulated? Remember, your master gland, your pituitary gland, is the one that really controls the rate of thyroid hormone production. So remember the hypothalamic pituitary axis. So here we discuss the hypothalamic pituitary thyroid axis. So how does this work? So your hypothalamus produces your TRH, your thyroid releasing hormone, which stimulates your anterior pituitary to secrete your TSH, and your TSH now is responsible for stimulating your thyroid gland to produce T4 and T3. So remember, your TSH modulates all the steps of the thyroid hormone synthesis from from iodide trapping to the thyroid peroxidase enzyme to the organification. TSH affects all of that. So if your T3 and T4 now sends a negative feedback into your anterior pituitary in order to either increase or decrease your TSH. If you have excessive T3 and T4, it will slow down the production of your TSH. If your T3 and T4 is lacking, it will now stimulate your anterior pituitary to increase its production of TSH in order to stimulate your thyroid hormone to produce more, your thyroid gland to produce more T3 and T4. So if you have excessive T3 and T4, you expect your TSH to be low. If you have low T3 and T4, you expect your TSH to be high. Okay, so again, your TSH increases thyroid hormone secretion by increasing proteolysis of the thyroglobulin, increases the activity of the sodium iodide importer, increased iodination of tyrosine, increased size and secretory activity of the thyroid cells, increased number of thyroid cells. No? So patients with central hyperthyroidism, no, patients who have excessive production of TSH coming from the pituitary can also manifest with goiter, no, because of the increase in the number of thyroid cells. Okay. So your TRH, that's your thyroid releasing hormones, regulates the TSH secretion by the anterior pituitary. So when a person is exposed to a cold environment, let's say you try to go to Antarctica, no, it will increase the activity, increase the production of your TRH. No, and the TRH will now in turn stimulate your TSH, and your TSH will stimulate your thyroid to increase production in order to increase basal metabolic rate, in order to generate heat for your body, no, as much as about 15 to 20%. TSH, no, extreme excitement and anxiety can cause an acute decrease, so you can have low TSH levels. So just to illustrate, no, so that you will be able to sort of grasp what's the mechanism, no, or the principles behind the hypothalamic, pituitary, and organ axis. No, this is very central to endocrinology. If you understand this, you will be able to interpret everything, almost everything, of course, not almost everything except calcium metabolism. Anyway, so if you understand the hypothalamic, pituitary, and organ axis, you will be able to easily interpret tests, endocrine tests. So for example, no, if you have a patient with primary hyperthyroidism, so your thyroid gland is producing excessive T3 and T4, it will result in low TSH levels because it will suppress your anterior pituitary. And then if you have, sorry for the arrows, if you have secondary hyperthyroidism, meaning the problem is coming from your pituitary, the excess production of there is excess production of your TSH, no, from the anterior pituitary. It will now result in an increase in T3 and T4. Sorry. If you have tertiary, just ignore the tertiary hyperthyroidism. If you have primary hypothyroidism, meaning your thyroid gland is unable to produce T3 and T4, let's say you underwent surgical removal of your thyroid gland, or you have destruction of your autoimmune destruction of your thyroid gland, you will have low T3 and T4 levels. No? What will happen in the thyroid function test, you will see an elevated TSH because of the negative feedback. In secondary hypothyroidism, the hypothyroidism is coming from the pituitary, no? Let's say you have an operation in your pituitary, and your pituitary is unable to normally produce TSH. Now you will have low TSH, and you will also have low T3 and T4. So I hope you understood that, because this is very, very important. So they're almost always opposite, okay? So elevated T3, T4, you expect TSH to be low. If low T3, T4, you expect the TSH to be high if it is coming from the thyroid gland. But if it's coming from the pituitary, you have elevated TSH, you also have elevated T3 and T4. If you have low TSH from the pituitary, you will also have low T3 and T4. So that's how they are related from one another. And this is because of the negative feedback mechanism. There are also such a thing as thyroid-stimulating immunoglobulins, and these are antibodies to TSH receptors on the thyroid gland. They stimulate the gland to secrete T3 and T4. No? So an example of this will be Graves' disease. In Graves' disease, you have TSH receptor antibodies. No? So these antibodies, what they do, they attach to your TSH receptor. So when they attach to the TSH receptor, it will activate the TSH receptor and result in, they act like TSH, but they're actually TSH receptor antibodies, and they are pathologic. So when they attach to the TSH receptor, so they act like TSH, they activate the thyroid hormone synthesis, everything, just like TSH, no? And this will result in high circulating levels of T4 and T3. So what do you think would be the concentration of your TSH if you have high levels of T4 and T3? You will have what? High or low? So you will actually have low concentrations of TSH. Remember your hypothalamic pituitary thyroid axis. So this is a picture of your Graves' disease. No? You will have the Graves, the thyroid's there. No? That's your Graves ophthalmopathy, because your TSH receptor antibodies also have TSH receptors behind in the fibroblasts behind your eye. You will have thyroid dermopathy, then you will also have thyroid acropathy, and the thyroid function test would appear like this: elevated T3, T4, and a suppressed TSH. So to summarize, no, so your hypothalamus, no, secretes your TRH, no, and this is affected by temperature. And your TRH will now stimulate your anterior pituitary to stimulate your thyroid to produce your TSH, and your TSH will now activate your thyroid hormone synthesis, increase its secretion, and your thyroxine, your T3 and T4 will primarily your T3 will increase metabolism in the cells, everything that we discussed, and they will now, their thyroxine will provide negative feedback both into your anterior pituitary and your hypothalamus as well. Okay, so this is just a summary of the difference the different manifestation of hyper and hypothyroidism, so that it will help you remember what are the functions of your thyroid hormones in the different organ systems of the body. Okay, I think this is my last slide. If you have any questions, I'll be more than willing to entertain your questions in our Q&A session. So, thank you for listening. Um, and I hope you consider also a career in endocrinology later on. Very, very easy subspecialty. Okay, bye-bye. The end.